evening, everyone, and welcome to the fifth episode of the Young ITI Agree2Disagree series. My name is Federico Ausenda. I am a periodontist from Milan, and it's my honor to be moderating this discussion, which is by the group of the Young ITI Italian section. I'm a periodontist. I graduated from Tufts University, and then I had the luck to be an ITI scholar at the Eastman Dental Center in Rome. And I'm very excited to be moderating today's discussion, along with my dear friends and very good clinicians, Doctors Paolo Carosi and Doctors Matteo Cordaro from Rome. Ciao Paolo, ciao Matteo.
Ciao.
Hi everybody.
So tonight's topic is a simple yet interesting one, which is tissue level versus bone level implants. And Paolo will be talking about tissue level, right, Paolo?
Yeah, thank you for the kind invitation.
Of course. And Matteo will be on the bone level team, right?
Yes, very, very ready and steady for the discussion.
Good. You guys are both based in Roma. Do you want to tell us a little bit about yourself?
Yeah. Hello, everybody. I'm Paolo Carosi, and I'm from the University of Rome, Tor Vergata. From where I graduated and completed my PhD last year. I started to investigate digital and oral implantology from 2017. And nowadays I'm a postdoctoral researcher at the University of Tor Vergata, and I'm following several research projects such as dynamic navigation, computer-guided surgery, and of course, tissue-level implants and their development through the years.
Matteo?
I'm Matteo Cordaro. I'm from Rome as well, as Federico said. It's a great pleasure being here tonight with you guys. Can't wait for the discussion. I'm a prosthodontist. I graduated from dental school in Rome, and then I had my postgraduate training in Geneva, Switzerland with Professor Seiler. And now I'm a PhD student at the University of Rome La Sapienza. My research topics are basically full arch rehabilitation, implant-supported full arch rehabilitations with a digital workflow. I really much cannot wait for the discussion to start. So I think we'll have a great night.
Yes, I think Team Italy can hopefully do a good job tonight, also because we have here, the point of view of the periodontist, the surgeon, the prosthodontist, so we can have a lot of things to touch upon. Just a reminder to the audience, during the discussion, you have the possibility to ask any questions. We have a live chat going on, so if there's questions coming from the audience, I will be able to ask our speakers. So do not be afraid, ask a question. This is why we're here. And also remember to follow us on the social media channels, Instagram and Facebook. So let's dive into tonight's debate. We will now start with the first speaker, which is Paolo Carosi, that will be talking about tissue level implants. Paolo, the stage is yours.
Thank you.
Welcome everybody, I'm Paolo Carosi and I'm really happy to join this new session of ITI Agree2Disagree promoted by the International Young ITI Group. Today I will be talking about tissue level implants, why and how we should use them. But first of all, let's have a look at the agenda. We will discover what it is a tissue level implant. We will analyze the clinical implications of tissue level implants, highlight the clinical scenario that may require more attention by the clinician, and finally, we will take a look to a clinical case from A to Z and to the final remarks. The tissue-level implants made their debut in the late 70s, and despite some changes in the intrabony part, especially for the surface, the philosophy behind never changed. Actually, a tissue-level implant is a one-piece dental implant with rough intrabony part and smooth machine neck, as we can clearly see in the photo. The intrabony part provides osseointegration, while the smooth machine neck provides attachment for the soft tissue. So the implant itself approaches the bone with the rough part, while the soft tissues are in direct contact with the implant from the time of implant placement, giving to the body a new architecture to build the peri-implant tissue, like the oral circular epithelium, the epithelial attachment, and the connective tissue. So, the placement of implants with a non-submerged approach allows the establishment of biologic width from the day of the surgery. As we can clearly see from this beautiful histologic section from Cochrane, the junctional epithelium stops its growth few microns under the sulcus, showing that no inflammation may compromise the connective attachment, enhancing the bone stability over time. But from a clinical point of view, let's see what it means to place a tissue-level implant for what it concerns the surgical, the prosthetic, and the maintenance aspects. A tissue-level implant may require a one-stage surgical procedure, and the clinician should place the implant as axial as possible because of the smooth machine neck. And also, an adequate keratinized mucosa volume is strongly required because we are going to provide to the body and to the implant itself a transmucosal healing, and what we really want is a coronal mucosal sealing that will stabilize the blood clot, providing and enhancing the osseointegration of our implant and the maturation and the growth of the soft tissue around the smooth machine neck. From a prosthetic point of view, the tissue-level implants do not have any kind of microgap positioned at the alveolar bone crest. Instead, the implant platform is positioned at tissue level above the biologic width, so the clinicians have easy access to the implant platform, especially for the impression that may be taken in an analogic way or in a digital way. Moreover, the inbuilt smooth machine neck do not provoke any interferences with the implant supracrestal complex, providing a feasibility for cemented or screw-retained prosthesis. Tissue-level implants experience high level of maintenance by the patient and by the clinicians, and also experience high level of implant survival rate in the literature. If we see this life table analysis published by Kim et al., we can clearly see after 10 years in function a high level of cumulative survival rate that is 98.23%. In this study, the authors placed more than 1,500 tissue-level implants, and the capability of the maintenance is really high. Moreover, in another study, we have low rates of pyrolimplantitis, but this study is published by Katafuchi et al., but we must say that these results are not statistically significant because this is not the primary aim of the study, so the power analysis was not calculated on this outcome. But why we have such low rates of parimplantitis and such high implant survival rate? Maybe because of the implant shoulder at the sulcus level that enhance the cleanability of the crown of the fixed prosthesis, and that is the top of the built-in smooth machine neck emergence profile that provide connective attachment from the day of the surgery. So we have strong attachment to the not only to the bone part for osseointegration, but also for the tissue level part. But what we should pay attention? Of course, when we place an implant, we should pay attention to the bone and to the soft tissue. We must have adequate amount of surrounding bone to place the implant, and we must have enough keratinized mucosa in terms of width and height. But especially for the tissue level implants, we have to be really, really careful when we study a clinical case like this, because in that case we have a shifting of the mucogingival line from the vestibular part from the more coronal part. And if we see in the literature, the best technique to augment the width and height of keratinized mucosa is the free gingival graft. So we perform the free gingival graft before implant placement. We wait for the maturation of the soft tissue, and then we go for implant placement, regenerative procedures, and transmucosal healing, and for also the definitive crown. In that case, we have reestablishment of the mucogingival line, the reestablishment of adequate volume of keratinized mucosa to provide crestal bone stability and soft tissue stability around the dental implant. Let's see now a clinical case in which we use the tissue level implant to replace a missing maxillary first molar. First of all, we go for X-ray inspection, and then we can clearly see that we have a lot of keratinized tissue. We go for full thickness mucoperiosteal flap, site preparation, and implant placement. In this case, we are not going to perform any kind of bone augmentation or soft tissue augmentation. We place the implant following the correct prosthetically emergence profile, and following, for what it concerns the vertical height of the implant, the ideal position of a tissue level implant, with the intrabony rough part fully engaging the native bone and the transmucosal part that is right above the bone, embedded in the soft tissue, as we can clearly see from the X-ray. So after the healing period, we have this beautiful tissue integration, not only for the intrabony part, but also for the soft tissue attachment around the smooth machine neck. And then we go for the definitive crown, that is porcelain to fused to metal single screw retained crown. So what about the final remarks? Single stage procedures may reduce overall treatment morbidity. Digital prosthetic workflow may be facilitated by the implant platform at tissue level. The smooth machine neck may enhance peri-implant stability over time. However, after more than 30 years of scientific and clinical expertise, no power study investigated the clinical performance of tissue level versus bone level implants. So I would like to thank you all for the kind attention, and I'm really looking forward to the discussion.
Thank you, Paolo. Very nice lecture. I just want to remind the audience that you can still interact and ask questions if you have any. Matteo will be up next, but you can still ask questions about the first presentation. And we will move on now with our second lecture by Dr. Matteo Cordaro, that will now analyze the pros and cons of bone level implants. So Matteo, it's your turn.
Dear colleagues, it is a pleasure being with you tonight. I'm Matteo Cordaro and today we will be talking about bone level implants. In this brief presentation, we will be talking about both the surgical part of our treatment and the different prosthetic options that we have when dealing with these fixtures. We will also focus on the main differences that we have between bone level and tissue level implants, of which Paolo will talk to you about tonight. In general, we can use two words to describe bone level implants: aesthetics and flexibility. Aesthetics because their main goal is to achieve better aesthetic results in a more predictable way, and flexibility because, especially when dealing with more complex cases, these implants present more indications and more options than the tissue level ones. Within our surgeries, we do not have big differences in the procedures per se between bone level and tissue level. What changes in particular are the indications for which we decide to go for a bone level solution. And of course, when we talk about indications in implantology, we have to talk about bone. With different bony situations, we need to take in fact different clinical decisions. For example, following this classification published by Professor Ammerle now 10 years ago, we can find different bony situations from 0 to 5. And within each class, the level of complexity increases. In the first two situations, we have basically an ideal case where no augmentation or a minor bone contouring of the implant is needed. In these cases, we can use a non-submerged approach. This technique let us be way less invasive, avoiding a second surgery and therefore lowering the time of treatment and, most importantly, the morbidity for the patient. Non-submerged healing can be achieved, of course, with a tissue-level implant or with a bone-level implant to which an healing screw is directly connected during surgery. Of course, the situation changes when we have a less ideal situation, such as in classes 2 and 3. In these cases, a more extended GBR is necessary. At this point, a submerged approach is almost mandatory. Therefore, it is way easier to use a bone-level implant, which can be inserted at the same time of bone regeneration procedure without the need to fear for a post-operative complication. By submerging the implants, in fact, we lower our chances of having an exposition of our membrane and therefore the loss of our graft. When we find ourselves instead in class 4 and 5, it is of course necessary to delay our implant placement after the integration of our graft, and therefore not even bone-level implants can help us in these cases. Let's talk now about the prosthetic options that we have with bone-level implants. When we treat patients with this, in fact, we have several benefits, of which we will list only the most important ones for timing reasons, of course. We can modify our emergence profile in order to achieve the best possible pink aesthetics. We can use a one abutment, one time approach, or in full arch cases, we can use multi-unit abutments. The most important aspect of having a bone-level implant when talking about aesthetics is the distance that we have between our gingival margin and the grayness of our implant neck. But of course, the main difference with dealing with a bone-level implant and not a tissue-level one is the transmucosal path and how we can modify this to achieve better pink aesthetics. By playing with the profile, in fact, of the transmucosal part of our crowns, we can achieve better clinical outcomes for our prosthesis. And while for several years convex profiles have been suggested to give great aesthetic results, recent studies have shown that we might incur in more frequent recessions with this design than with a more concave one. Critics for the concave profile say that this kind of design is not ideal for the cleansibility of the prosthesis. Unfortunately, we still don't have enough evidence to support any of these two approaches. But a quick but important mention needs to be done for the group of Zurich, where in particular Franz Strauss and Leonardo Mancini are developing clinical studies to investigate the importance of the angles that create these emergence profiles. In fact, when we design a concave profile, it is not that we have always the same concavity. Depending on the angles that we design and reproduce within our crown, we can have very different results. This might change our cleansibility and therefore our prognosis in the long term for our implants and our rehabilitation. So talking about the emergence profile, this is of course also characterized by the soft tissue seal that healthy gums create with our prosthesis. This seal can be broken when the prosthesis gets unscrewed or discemented, as per example with the provisionals, and this may lead, some studies suggest, to an increase in bone loss around implants. The one abutment one-time approach tries to avoid this problem by using a customized abutment that once connected never gets unscrewed. Of course, this forces us to use a cemented approach and may incur in long-term problems when dealing with the physiological recession that we encounter with aging. In fact, as in this case, if we have a customized abutment with made in zirconia or worse in titanium, when we have a recession, we might incur in a lack of aesthetics for our patients. Last but not least, we have multi-unit abutments. These are widely used in full arch implant supported restorations to compensate the implant's divergence and to bring our prosthetic platform away from the bone to improve cleansibility, and therefore our implant prognosis when we go for hybrid restorations. As final remarks, it is important to talk about the 4 topics that we discussed. As surgical treatment, we mentioned more flexibility that we have with bone level implants at time of implant placement, especially when we have more extensive need of more extensive GBRs. The emergence profile, the chance to condition soft tissues to achieve better aesthetic outcomes, the one abutment one time concept to avoid the interference with soft tissue seal, and the multi-unit abutments, where these secondary abutments are used for full arch restorations, especially when we are dealing with angulated implants. With this, I would like to thank you ITI for this great opportunity, and thank you all for the attention.
We're back. Well, thank you, Matteo, and congratulations to both of you. I think the presentations were both very interesting. You touched on a lot of topics, lots of concepts that I think we hopefully are going to have enough time to debate right now. We're already having a lot of interaction on the platform. Thank you, Taimur. And I think we will start with a question from the audience. We have a question from Abhishek that is asking, what are the contraindications for tissue level implants? So I think this would be a question first for Paolo, since you talked about tissue levels. When you think about tissue levels, what do you think about contraindications?
Well, thank you, Federico, and thank you for the kind and very interesting question. Well, the contraindication for tissue level implants, we can say that are maybe the ones that Matteo showed us as the indication for bone level implants. Let me better explain. So what I think and what I do in my daily practice is to think about bone level implant, especially when large GBR are needed. So when, as Matteo showed us before, when we have a large need of bone augmentation and we cannot achieve a good mucosal sealing, a good flap sealing, and the stabilization of the blood clot to enhance the osseointegration and enhance the bone regeneration with a transmucosal healing, so with a tissue level implant. So that's the moment when maybe a bone level implant can be a good solution if we want to do a single stage surgery. Of course, if we want to place the implant, we want to regenerate the bone, augment the bone, and also go for submerged healing. So maybe this could be the indication. Also, I guess that maybe we can debate on the aesthetic zone, but it is not a real contraindication. It is more maybe an indication for bone level or tissue level. But for the contraindication, I would say that the possibility to seal and to close the flap properly to have a good GBR, good bone regeneration, and osseointegration in the meantime, at the same time, that is maybe the contraindication.
So let me see if I understand correctly. I think this is interesting because we all tend to think more on the things that we do. And I know, Paolo, you are a surgeon, so you're saying I prefer to utilize a bone level fixture if I have to do bone regeneration because that allows me to have a submerged healing. I think, Matteo, there might be also some prosthetic considerations.
For sure there are some prosthetic considerations to do. I wouldn't talk about contraindications per se because we have amazing results from Professor Buser and Professor Belzer that live up to 20, 30 years follow-up. So I wouldn't call them contraindications for tissue level implants. I would say that probably in most of us in our daily practice, bone level implants might be easier to handle in certain situations, especially from a prosthetic point of view. I would say definitely one of like the only contraindication that comes to my mind is the one that is bound to the initial bone situation. So if we need to submerge and we have, for example, we have some thin soft tissues, it might be easier to handle the situation with a bone level implant. That might be a real contraindication for a tissue level implant. Otherwise, from a prosthetic point of view, it's not really a contraindication, but it's just the easiness and the more flexibility that you get from a bone level implant, especially in the anterior area, of course.
What about prosthetic space with tissue level versus bone level?
Exactly. Of course, I mentioned this in the presentation. With bone level, we have much more space to play with our soft tissues. We have so much more space to then condition our soft tissues as well and try and create a more aesthetically pleasing emergence profile, zenith of the gums, in general, pink aesthetics. So this is one thing, and this is, at the start of our treatment. I would say that thinking a little bit more into the long term, we could also say that using a bone level implant could make our life easier when we have some kind of like physiological recession around the implant. So we have a little bit more space. We have a little bit more a safety net. Let's call it this way with a bone level implant. So I wouldn't talk about contraindications for soft tissue for tissue level implants. I would just talk about the advantages and let's say the flexibility of bone level implants.
Thank you, Matteo. Lots of questions are coming in the chat. We have a question from our friend Minoru. that has to do with the apical position, the apicocoronal position of the fixture. And he's asking, particularly for tissue level implants, what's the correct height? So the rough smooth interface should be placed at crestal level or subcrestal? Paolo, what's your comment on that?
Well, that's the best question that could be made tonight, because this is one topic that always is hard to find a consensus. And I would say that we to answer this question, we have to think about the biology. So when we place an implant, when we go for a full thickness surgical implant placement, we are going to detach the periosteum from the bone. So in that case, for every patient, we always have 0.5, 1 millimeter of bone resorption. So, as Professor Buser, as Matteo said before, from 30 years, always tell us and teaches us how to place tissue level implants, it may be better to place the rough, smooth interface 1 millimeter below the bone crest. But it's just because we're going to expect a little bit of bone resorption around our implant, despite bone level or tissue level. But in tissue level case, we are going to prepare also the most coronal part of the bone crest to attempt to place in a correct way the machine neck that has not the same diameter as the intrabony part. So the rough interface, the rough part of the tissue level should be placed 1 millimeter, 0.5 below the bone crest if we are going to do a full thickness surgical procedure in order to prevent the bone resorption and to not have a recession. And recession of the bone, so that clinically we have recession of the bone that shows up a recession of the soft tissue, and so we have the smooth machine neck that is right into the patient mouth, and we can clearly see in the patient mouth through the gingiva. These kind of recession are always hard to treat, especially from a soft tissue handling point of view. So this is my advice.
So Paolo, you're saying that you obviously place the rough surface of the implant in bone, and then your personal preference is to try to sink part of the smooth transmucosal collar, about 1 millimeter, you say, subcrestally, because you anticipate some bone remodeling. Matteo, I know that there's different kinds of tissue level implants. Yeah. Some of them have a longer transmucosal portion, and others a little shorter, like 1.8, 2.8. Yeah. What's your preference on that? What's your rationale in when you decide to use one or the other?
Well, generally, I tend to use a little bit more the 1.8, let's say the shorter neck tissue level implant, as just because like having a shorter neck gives us a little bit more space once again, so we can somehow have some more space to have a nicer emergence profile. Just to reconnect a little bit to what Paolo was saying, I couldn't have answered in a better way than Paolo did. I remember that we had a very memorable discussion. This was like 4 years ago in Geneva, and this was the topic, and we had a really long discussion with the team about this topic. What I following the literature, following what we have at the moment as data, probably the best idea would be to go, as Paolo was suggesting, a little bit deeper with our implant, and 1 millimeter, even slightly more than 1 millimeter. This way, when we have the 1 millimeter of bone loss due to the flap elevation that we are expecting, when the resorption stops, the bone will still be on the smooth surface of the implant. So this way we only have smooth exposed surface of the implant. This might be of uttermost importance to deal with or to avoid as a first instance periimplantitis in the long term. So I'm 100%. I 100% agree with Paolo on this point. Concerning the different length of our neck for our tissue level implants, so this becomes the topic. As I tend to place the implant slightly deeper than, let's say, an old school implantologist would, I tend to play with the length of the neck to try and still have a nicer emergence profile if needed, of course. Otherwise, I try and be as shallow as possible. Absolutely. If I'm in a lower molar area, I try and be as shallow as possible, 100%. But if needed, for example, if we're on like a periodontal patient, second premolar, upper premolar, this could be a nice way to, to play with our chances for the future.
Thank you, Matteo. And I think you guys, your answer might partially explain the reason why, like Paolo showed us in his presentation, we do have evidence that tells us that tissue level implants seem to perform very well, particularly in terms of lower rates of biological complications over time. There's another interesting question by the audience, by Carla. She's asking us about implant fracture. And she's asking what you guys think in terms of small diameter tissue level implants. Are they more prone to fracture compared to the same diameter bone level implants? What do you guys think?
I may start with this. I think this issue was much more present when we were using like the initial titanium alloys that we had for our implants. I think now with titanium and zirconia alloy, the issue is way less. I think there is data about that. I cannot go by memory and quote it by memory, but I do remember this. I would still say that probably the choice of implant should always be thought and made seeing the clinical situation. So if we have a heavy bruxer, if we have a very big tooth to support with a very narrow implant, probably it would be better just to go for a bone grafting procedure and choose a wider implant. In general, I mean, if we talk about narrow implants and with a tissue level, I mean, if you're on a premolar, probably it is not a big issue if there is no parafunction within the patient. Of course, if you start to go more distal, if you go with an narrow implant on a molar, then I mean it starts to get trickier for sure.
Paolo, do you have any comment?
Well, Matteo perfectly describes what is, I think, the modern implantology concept. So, in every clinical scenario, when we start to think about how to treat our patient, we have to make choices, and choices are made by our brain, and our brain have to work in constantly development, and should always pay attention to the whole patient, not only to the single surgical procedures or to the single prosthetic procedure. Prosthetics and surgical should always go together. So the analysis that Matteo just made is really good, and is what we always have to. Is what we should always do, and we always have to think about it, because we cannot place a narrow implant in a very narrow crest in the molar side. We can go for overloading of the implant, and before implant fracture, we may have also peri-implantitis due to the overloading. So every implant has its indication, and we should always follow the prosthetics. And for what it concerns the questions, I do not remember in the recent times any kind of fractures of the narrow tissue level implants. I saw maybe one or two implant fracture from implant placed maybe 30 years ago, from the very first titanium alloy, as Matteo said. But nowadays, I'm not afraid of implant fracture. I'm more afraid of peri-implantitis.
Okay, thank you, Paolo. I think we agree on the fact that it's not very much the diameter, but more the material of the implant, and the older titanium alloys had a higher risks, particularly on a narrow diameter implant. I think there's too much agreement in our Agree to Disagree session tonight. You guys are on the same page all the time, but it's good, I guess you have the same mindset. I think there is an interesting question by Taimur that is coming up. And Matteo, you mentioned the one abutment, one time concept. And Taimur is asking, isn't the one abutment, one time concept with no microgap the same thing that happens on a tissue level implant?
First of all, thank you, Taimur. Great hearing from you. You can definitely see it as he mentions, like a tissue level implant is a one abutment, one time concept. Basically, it's the original one abutment, one time concept, and the basis and the, how would you say, I think the biological basis that is up underneath this concept is basically the same as a tissue level implant. There is only a major difference that I would say that actually makes things not quite the same. And this is the fact that with a one abutment, one time concept, if anything goes wrong during time, you always have a safety net to just unscrew the abutment and deal with the problem, with the problem in an easier way, having a bone level implant. When you have a complication, sorry about that, when you have a complication with a tissue level implant, especially if you're in an aesthetic or near an aesthetic area, might become very difficult to deal with. So yeah, I would say this is the main difference. You have, with the one abutment, one time concept, you have a safety net. I have to say it's an expensive one, because customized abutment with a crown. It's an expensive one, but it is a safety net. As you see, I'm always talking, more in the future. I don't talk about long term. That's because working in private practice, you always need to think in the long term. I think this is one of the most important things. So I would say that still it's very similar as a concept, but still one abutment, one time in that regard might have more an arrow more in your arch. Yeah, basically. Weapon.
Maybe we can find some disagreement here. Paolo, what's your opinion on it?
Well, I'm afraid that in that case we have to agree again because because as I said, for what it concerns the implant depth placement, biology never lies. We can tell us whatever we want, but the rationale behind the one abutment, one time, Matteo perfectly said, is a tissue level implant. And behind the tissue level implant, there is a biologic concept of transmucosal healing, of the reestablishment of the biologic width, implant supracrestal clamps. We can call it whatever we want, but it's that. So we are stabilizing our blood clot that would form bone, connective tissue, epithelial attachment, and the junctional epithelium through the sulcus. So we are not going to do something different with the one abutment, one time. Of course, it is easier and is flexible. Matteo perfectly showed us in his presentation that with bone level we have flexibility. With tissue level implants we have one shot. We place the implant and that's it. We are not going to change the emergence profile. The emergence profile is provided by the industrial manufacturing. So we do not have that kind of flexibility. But the biologic rationale behind the one abutment, one time is for sure the rationale that more than 40 years ago tend to develop the tissue level implant, in contrast with the the first bone level implant, of course.
Thank you, Paolo. There's one more question by the audience. And it's one that I think it's really important, being a periodontist. It's a question by Miriam, who is asking about cleansability of implants. And I think it's something very important because of biological complications. And I think it relates to a lot of things we talked about tonight, from implant position to type of implant to emergence profile. Matteo, what do you think could be? How would you answer this question?
So it is a very, very difficult question to answer, actually, because to clean the prosthesis, hopefully not the implant, because if you're cleaning the implant you already have a problem. To clean our prosthesis, we really need to design
a cleansable prosthesis,
our crowns, our bridges in an optimal way. So we need to take care about embrasures. We need to take care about the emergence profile. And as I showed in my presentation, there is no consensus on the kind of emergence profile that is needed, and it is best for cleaning and for a long-term good outcome. So basically, at the moment, we've done for a very long time. We, as prosthodontists, we've done for a very long time convex profiles for our crowns. This has shown very good cleansability for sure. But this, as I was showing the graph from the paper from Zurich, it started to show, the paper is from Professor Dani Toma, it started to show, the convex profile started to show a little bit more recession, more rate of recession than the concave profile. So at the moment, as we do in the literature, and on this there is still no consensus. But what we do clinically is that maybe if you need to push your soft tissues away, maybe you need to have somehow a longer crown. It's easier to go for a convex profile. If you need to have more tissues there, it's easier to go for a concave profile. The problem with the concave profile is that you can, as I was mentioning, and this is this was the topic for the PhD of my very dear friend Leo Mancini with Franz Strauss in Zurich. You can actually design a concave profile in 10,000 different ways. Changing the angles, you change completely the design of this curve that you are creating, that you're producing with your crown. Of course, the steeper the curve is, the more difficult the more soft tissues you'll have in the beginning, but the more difficult will be for the patient to clean. And for sure, you will have more soft tissue. But if you have a steep curve, probably when you start having recession, the recession will have a bigger impact from a pink aesthetics point of view. So I think how we manage cleaning the implants, it depends. Depending on the case, we need to decide for the easier design. But this is of uttermost importance. As Paolo was mentioning before, our main issue nowadays is not osseointegration, is not implant fracture, is periimplantitis. And since day -1, we need to take care of this topic, and we need to have this in mind to avoid it as much as possible for our patients.
Yes, and I think this is very important. In fact, the recent guidelines of the European Federation of Periodontology actually tell us that prevention of peri-implant disease starts before we even place the implant. And when we talk about cleansability, Paolo, I think that tissue level implants are a very good option for our patients, don't you think?
Yeah, of course. And I would say, before answering to this question, that I really like this format because we are going to analyze every aspect of the implant prosthetic rehabilitation. Matteo has a great experience in prosthodontics, so in prosthetics. So he analyzes perfectly what it means to have cleansability of the prosthesis. But of course, we have to keep in mind that the best treatment is prevention. So to prevent the bacteria to go into the surface, to reach our implant, to clean the implant, but not really the implant, but the gingiva around the implant, so the peri-implant tissues, we have to manage properly the soft tissue. We have to provide to our implant a good soft tissue integration in order to avoid the penetration of the bacteria that can start with the mucositis and follow with periimplantitis. So of course, the design of the prosthesis is crucial, especially for bridges or full arch cases, and also for the bone level implant because of the transmucosal part of the abutment and of the prosthesis, of course. For tissue level implants, we do not have that kind of problem because the the emergence profile is provided by the implant itself. So the best prevention is to handle properly the soft tissue to provide adequate volume of keratinized mucosa to have a strong gingival attachment to the implant and to the transmucosal part, and of course to motivate the patient, to let the patient understand that the implant is not forever.
Very good point, Paolo. Thank you. So I think we are reaching the end of our talk tonight. So I have a final question for you both, but I don't want you to answer it right away. Just to sum it up, the question is, there's young dentists out there that are watching us this evening. And say I'm a young dentist and I want to start to place dental implants. Would you advise me to start from only tissue level, only bone level, or both? Think about your answer. Before you answer, I want to give a reminder to everybody that ITI is having an amazing event in Singapore in May. Before this event, we will have a day that is dedicated to the young ITI. It's called ITI Young Day. It's a full day where we will have lots of young speakers from all over the world present their clinical cases and their research. So don't think you should miss it. It's a fantastic event. The QR code is on the screen, so you can take a screenshot of that, or just take a screenshot of the QR code, and it will link you to the page that talks about the event. And this is going to be just before the ITI World Symposium that is going to start in Singapore the day after the event that I just talked about. It's an event where we'll have thousands of attendees from all over the world, top speakers, top clinicians and researchers, and a great opportunity not only to learn, but also to network and enjoy the beautiful city of Singapore. It's in May, and you can just look at the QR code and it will send you right on the web page. So guys, I'm a new dentist. Bone level or tissue level? What do you recommend?
Very good question. Very good question, and I would recommend you to properly analyze your case. So if it is a straightforward case, lower first molar, enough bone, enough soft tissue, go for a soft tissue implant, tissue level implant. Sorry, in order to have not aggressive at really smooth surgery, and of course long-term stability of the peri-implant tissue.
Matteo?
My suggestion would be to study, to make as much experience as possible with all the weapons that we have, all the tools that we have, the techniques that we have, and try to use every tool that you need in every situation. Having said so, in the anterior 6, nowadays it's more and more the anterior 8 of the upper arch, I would definitely go bone level.
Thank you, guys. I think it's been a very interesting evening. Thank you for your time and your expertise. I want to remind everybody to follow our pages and like and subscribe. And also, I want to remind everyone that our next Young ITI Agree to Disagree episode is going to be episode number 5 by the Taiwanese section. And their topic is going to be an interesting one. It's going to be static versus dynamic guided surgeries. So mark your calendars, March 21st. And again, Paolo, Matteo, Young ITI, thank you so much.
Thank you, ITI. Thank you, Fede. Thank you, Paolo. Thank you, everyone who attended and made very interesting questions. We had a few prepared, but you made very, very interesting questions. Thank you, everyone. Thank you to the organizers as well.
Yeah, thank you for the kind invitation. It was really, really, really fun, and was, I hope, really interesting for the audience.
We look forward to our next episode.
Yeah.